All right. So this is the alternative, what do we call it? The alternative 911 response subcommittee, I think. Evangeline and I were trying to mumble through a name on a different meeting. But we know what we're tasked with. This is our last meeting of this year. We will still try to get a couple more people. I'm still waiting for Cahoots. I think they're going to maybe make it in January, and also thresholds. And then, kind of in my mind, I think we'll go to the what is it, Human Services Committee in February, because they only meet once a month. So we'll probably get to them in February with some recommendations. I also think I have a line on some new money I'm super excited about. We have the Mental Health Board, Alderman Ravel, that has not been allocated. And I think this falls right in line with Mental Health Board funding. So I'm making a big pitch for that. Alderman Ravel is going to help me make that pitch, but that will be, I think, a game changer if we can get some more money behind this program to actually make it be impactful. And then we also, for an update, are still looking at the contract that we have with Amita that does the crisis line and some other services. I think we're going to kind of reframe that contract a little bit more, that we can be able to either use them as kind of a more long-term care for folks who might be responded to by whatever response model we put together, or even using them in some form for the response care. So that's another possible option we can coddle together. So that contract will be up at Human Services in January or Council in January with some edits that we're putting in there. So Alderman Ravel and I will look at that and see how we can flesh that out. But in the meantime, come on in. Sorry, the household people. In the meantime, Megan is here. Megan, I'll let you introduce yourself and speak for yourself. I believe you work with some people on this call, or at least you know them. But we are, Megan, just so you know, tasked with trying to put together an alternative to police response for folks in our community, so much like you're seeing nationally. And I can't remember who on this call mentioned that you all already do some work like that. So we wanted to hear what you guys do, how you do it, if you have any suggestions for us. And then as we're putting together our model, we have not decided if it's an RFP model that will go out for service, or is it in-house model. So just know there's a chance we could be revisiting you in a different light. I'm going to turn off my volume here so you don't hear all of my stuff going off. And Megan, you take it away. Or maybe, should we introduce ourselves to you? Would that be helpful, Megan?
Yeah, sure. If you'd like to. I do know some folks, but some people I don't. So
I'm Cicely Fleming. I'm alderman in the 9th Ward, and I am chair of this committee. And then if you guys just jump in, I won't call.
I'm Eleanor Ravel, and I'm 7th Ward alderman. Hi.
Hi, I'm Evangeline Seamark, pronouns she, her, and I'm representing as a community member who's a survivor of violence.
I'm Patty Capucci, Executive Director of Impact Behavioral Health Partners.
I'm Kristen Kennard. I'm the Deputy Director and Director of Social Work Services at the Moran Center.
I'm Maureen McDonald with Peer Services.
Hi, I'm Angela Valavanis. I'm a business owner in downtown Evanston and an Evanston resident.
Megan, we have 2 more committee members who might join us later. So.
Oh, sure. No problem. Sounds good. Hey, everybody. Thank you for intros. My name is Megan Miller. I'm the Director of Intake and Business Development at Trilogy Behavioral Healthcare. So I oversee our intake department that provides intake services sort of across our service area for behavioral health and co-occurring disorders, along with like some very specialized projects specifically focusing on inreach to jails prior to COVID and like just citywide initiatives through class member programs across the state and just other city initiatives in Chicago of linking folks to CST and ACT, more intensive behavioral health services. A big part of that component is overseeing our community crisis line. We've received this funding for, well over 7-8 years. I've been at Trilogy for about 8 years. We've had some form or fashion of a community crisis line since I've been at Trilogy. And really the purpose of that line is open to individuals in the community to utilize when there is a crisis. Certainly that crisis has ranged from, I just need some access to services. Can you connect me to your intake? Can you point me in a particular direction? This is what I'm looking for, all the way to facilitating a hospitalization if it's needed, through calling 911 and some other responses. So that's just like a little bit of a brief synopsis, and I can dive a little bit more deeper into that. But our crisis line is via phone. Back prior to COVID, we just literally just rotated a phone amongst the on-call staff. So we do not use a call system that folks call, and then they route the calls to an on-call clinician based on the type of call that is received. So I do carry the phone. So if I'm on call, those calls are directly coming to me. So I'm not sitting somewhere. It's just, I carry it with me throughout the day. Previously, probably about 2 years ago, we had clinicians that were master's level clinicians, some licensed practitioners, others just master's level social workers or counselors. And they were the ones eligible to carry the phone. And we carried it for a week, 24 hours a day. So we were responsible for responding, during business hours or outside of business hours and on weekends. Probably the last 2 years, we shifted focus and broke those shifts up, where it gives folks a little bit more flexibility in scheduling, not having to be on call 24/7 for a full week. And we broke those shifts up on a Monday to a Wednesday to a Friday, and then a Friday to into that following Monday, and then we rotate it. Right now, the calls are just transferred to a particular phone number that we identify. I like my personal phone, so they're transferred to me on my personal. Others just prefer to use their work phone, so they have those calls routed to those phones, and we're responsible for picking up the calls and responding to those crises. So typically, if they're during business hours, oftentimes we're either responding ourselves or reaching out to our intake department. I'll use an example. Perhaps somebody's calling, they just left the hospital, they're wanting to get access to services. They may not be in a crisis, but without access and immediate linkage, they're likely to be in crisis. So I may get some information, some identifying information, a little bit to help guide the process of linking them to our intake department. Typically, what I will do is figure out, where their location is, how can I support them with getting to one of our intake access points so that they can link with an intake worker and potentially, go through the process of receiving access to services, whether that be case management, therapy, intensive outreach services on like one of our case management teams that covers services across our service area. So that's one particular example. Another example is we have had community members call, hey, my neighbor, I'm very concerned about my neighbor. They are exhibiting, bizarre behavior. They're banging on the wall, they're yelling. I'm really worried about them. This is new. It seems like they're in distress. Can you provide some guidance or some information on how we may be able to help them? Sometimes it does result in an outreach attempt to say, hey, it sounds like maybe we could stop by or see if we could maybe potentially speak to this individual. Sometimes community members, if they're more involved with that individual, they're more than willing to be like, yeah, I could help facilitate that. If not, typically we will just do an outreach effort to try to engage, attempt to build some rapport, see if there is an immediate need for a hospitalization. Are they at risk of harm to themselves or others? Maybe we're able to ascertain if they've been without medications for a certain period of time, or they were connected with a provider but lost touch. Otherwise, if there seems to be a more immediate risk, we will facilitate a 911 call in partnership with whoever is on the line with us. So in this particular scenario, I might say, hey neighbor, it sounds like, I am concerned about this individual's safety. Might we request a CIT officer to see if they can come out to the home and see if there's a possibility of getting them to the ER for a crisis assessment with a crisis worker. And sometimes we're able to facilitate that if we're not able to immediately get out there in person for whatever reason. Many years ago, we did respond in person after hours. We have sort of moved away from that for purposes of safety, because I would be like myself responding to independently unless I'm able to go out with somebody, and typically that isn't always a scenario that's available. Certainly if there is something that we feel like there is an immediate threat, but they definitely do need an outreach, we may pursue a follow-up the next day. You know what, let me call Area North and see if I can't get in touch with the CIT officer so we could do a wellness check with this individual. So we don't have to involve police. We can do the wellness check. We can see what's going on, what information is needed at that time to be able to identify whether or not they need a hospitalization at that point, or can we just bring them to Trilogy for an intake and linkage to services? So that's definitely a scenario or an option that has taken place, especially for those that are receiving those crisis calls. This is probably what happens more often than not, where we get ER social workers or personnel calling our crisis line. It comes from St. Francis, a little bit of Evanston. I would say it's more St. Francis, and then certainly hospitals in the Chicago area that are calling and saying, like, I've got Joe here. Joe's been by, several times over the course of the last 3 or 4 weeks. He does not meet criteria for an inpatient hospitalization. However, it is apparent that they may need some support with access to medications, case management, a nurse, a community nurse that can do outreach. He's gonna hang here for a little bit before we are discharging him. Can you come out and see if there's any way that you could link this individual to some supportive services? Sometimes it's with Trilogy, sometimes it's with another community provider. So we really backed away from that during COVID simply because ERs, hospital systems were really dealing with the pandemic and, not wanting sort of extra people in those spaces especially when they're trying to deal with a public health crisis. But prior to COVID, we would go out. We set a response time for our clinicians. You have 90 minutes to respond for a non-emergency, service. In those cases, typically those individuals aren't in a crisis. They are at the ER, either awaiting discharge, or they may require an inpatient hospitalization. And likely there's usually efforts on our part to see if we can intervene on that time of the ER stay. So then when they transition to an inpatient unit, we've already made contact. I find out where they're going, and then we can work with the inpatient social worker on that psychiatric unit to try to pair to services upon discharge. That was usually our typical scenario for responding in person to individuals that needed connection to services. I think the response time helped, the clinicians to know, okay, this is how long I've got to get out there. This is some information that I need to know. And so there was that connection piece with that social worker or ER provider of, can you give me a little background of what's going on? Did they come in under the influence? If they're under the influence and they're sleeping, are you going to kind of let them sleep? Maybe I can come on the tail end of, when they're waking up and like getting ready for a discharge. Do they appear agitated or aggressive? How can we get some information that's going to help prepare us for when we do arrive so that we can do a screen and link to services at that point? So those were and those are some typical scenarios of how we do and have responded in person when there is an on-call provider. There are a significant amount of calls that we do get that are not necessarily crisis related. There might be somebody that just like, I'm not doing well. I just need to talk. I need a platform, just somebody to listen to me. We take that opportunity to engage and see, where from there we can link that individual if they are interested in services. Certainly it's, individual choice, but we use that opportunity to see if there's something else that we could potentially link them to. We get a significant amount of calls from just community members. Hey, there's an individual that hangs out in this particular area. They appear to be homeless or struggling with mental health needs. And I notice that they typically talk to themselves or they're shouting. Is it possible for somebody just to come out on an outreach attempt over the course of time in an attempt to try to engage an individual potentially into services? I think one of the main things that with scenarios like that, it typically takes several occurrences and connections with folks to try to build rapport and trust where they're like, okay, sure, I'll come to Trilogy, or you can take me there, or I'm open to that. And so I think that piece is when we've sort of referred to our like homeless outreach team of just like, hey, this person really is going to need several touch points than me as an on-call crisis worker is able to provide in that moment. Let me make the connect. Let me see if I can link you to them and see what you can do over time to sort of build and engage, just provide that support. I will pause there. I'm not sure if this is kind of what you were looking for, of just sort of information sharing, how we approach these sort of crisis on-call services. Happy to answer any questions or expand upon anything I have touched on so far. And I know I want to be respectful of your time. I know you have other folks coming on.
No, that was so much information. I think there's probably a lot of questions. So you all just chime in with your questions. I have some, but I'll wait till the rest of the group goes. Anyone with questions?
Well, just at the very end, you mentioned the homeless outreach. So do you, if you build a rapport with someone who seems to be homeless and needs some kind of homeless, housing assistance, do you partner with an agency to help provide the housing piece, or what happens in that?
Yeah, so it's really like there's a variety of scenarios. Typically for our PATH clients, and that's like the homeless outreach program, when they're engaged through that program, they're eligible to be placed on like the HMIS or the statewide referral networks that are pulling folks for housing, whether or not they have an income. We do have like different partnerships with various shelters or Mercy Housing. We ourselves don't necessarily have like immediate available housing where we're able to outreach and say, yep, like let's plug it in here. And so really it's just linking to that individual, helping them access resources that could potentially lead to housing. Are there barriers to that? Like they don't have an income, they don't have any insurance, they don't even have access to medications or food. So our main goal in those moments is to really try to meet those immediate basic needs, see if they can utilize our warming center or drop-in up at 1400, and then try, to link to various like housing or shelter placements upon linkage to services. The other thing like we have done, is making sure like if they're in an encampment or hanging out by themselves, where they can try to be as safe as possible. And do they have like appropriate clothing, a tent? We have provided more basic essentials just to ensure the safety of that individual if they are, continuing to remain homeless. Oftentimes, like another barrier for folks, and we've experienced this with like some of our programs that are grant funded that do have some housing opportunities, is for folks that have experienced chronic and long-term homelessness, going into an apartment has been very, very challenging for them. And it hasn't felt like a safe space. They've secured housing, they want housing. When they get it, they don't stay and they feel more comfortable being on the street. And, certainly I think our approach is like, how can we meet those immediate, like basic needs of like, how, you are on the street, how can we make you feel as safe as possible? And what are some other ways that we can like provide support and intervene so that potentially down the road, you feeling safe in an apartment of your own is going to be helpful. So.
And then I guess just one other question. You mentioned sort of in terms of like a wellness check and the feeling if you're after hours, not wanting to just go by yourself to touch base with somebody. Would you feel comfortable if you had a partner in these kind of situations, or do you think you'd need a police officer with you to do a wellness check?
Yeah, so I think it depends on the amount of information that you're able to receive. I think it can be very startling for people just to like have somebody show up on their doorstep of just some random person being like, "Hey, your neighbor called. You doing okay?" And that can be very, very startling and especially if you're experiencing like delusions and paranoia and like challenges with like your mood, like that can be very startling. So I think that what I've experienced that like daytime outreaches, particularly like homeless outreaches, if I'm able to make a connection with somebody that like, yep, I'm going there. Is there like, do you want to go with me? You're a familiar face. How can we sort of, bridge that gap so I'm not bombarding somebody, especially if I don't feel like right now it's an immediate crisis because I don't have enough information. I'm really doing a wellness check to see if anything else is needed. I will typically call area north and see if a CIT officer can come with me. In the event that I am, whether it's me or I'm with another individual, if it escalates to a point and I do have to call 911, I really want to prevent it from getting to that point. And so I think that some of the clinicians have felt like more comfortable. I typically start at least with a colleague of mine, get as much information. Can I bring in a familiar face that like this person is familiar with and see how we can approach it from that aspect before we involve any sort of like officer, and I know like a CIT officer, like they're still in officer uniform. And so like even then it can still be very startling for people. So we really try to see what we can do on our end to respond to that wellness check or that crisis before we are making a decision to escalate it to, wow, 911 is really needed, because at this point, they do need to go to the hospital and I can't transport them.
Anyone else with questions? Go ahead, Angela.
You mentioned you help people who are transitioning out of the hospital. Did you also say that you help people who are transitioning out of being imprisoned?
Yes, we do. Cook County Jail or the prison system will get referrals from like shelters, a Safer Foundation, various like clinics, and often hospitals. I mean, we see a lot of folks like, coming newly out of prison or jail that have been out for a couple weeks and they've really struggled. Like if they were receiving meds and some type of support in jail, it can be a real struggle to maintain that type of level of support when you're out. And typically folks go straight to the hospital. And so we do get some referrals from hospital systems for folks that are reintegrating.
I had a question. So you mentioned getting some calls from St. Francis, but with your funding and your operation, are you geographically, do you only do, Chicago and the south side of Evanston, or can anyone call you and ascertain your services?
Yeah, so the community crisis line is open to anybody in the community. I have gotten random calls from people out of state even, and it's, you're like, oh gosh, how did you get this number? It's so, surprising. But I think like we come up on our website, like it's posted various places. It's posted like on the DHS website. So yes, anybody could call. I mean, you could call and somebody would answer. It's open to anybody, not just folks engaged with Trilogy services or not just folks calling from a hospital.
Okay. And if someone does call, what would they have to do to then become a Trilogy client? So if they need long-term support or therapy?
Sure. So the use of the crisis line is not like necessarily to provide any sort of intake services. At that point, one, make sure like, is this person in a crisis and do they need something immediate because they're, a harm to themselves or other people? If they're like, no, I'm like really just calling, like, I really do need some support. Probably usually what I do, if it is me picking up the call or anybody else, we will just kind of get some basic information. Hey, like, what are you looking for? Where do you live or hang out or spend most of your time? What do you think would be helpful to sort of like help you get back on track? And then we usually what we'll do is if it's like after business hours, then we'll say, hey, why don't you come tomorrow to our walk-in intake services and you can sit down with somebody uh, and get linked to some services. If a walk-in option is not available, then I will have an intake worker from our department call that person the next business day.
And is that
Um,
walk-in open to anybody?
Yes, yes.
Okay, and so then back to the like wellness or any kind of, going to the hospital or, anything like that that would come into the, I guess maybe through the crisis line as well, or get, brought to your attention. If you go to the hospital and the person again needs these kind of long-term supports, would you take them from the hospital to another location? Do you just kind of check in on them in the hospital and then do that like call me tomorrow, let's connect tomorrow? I guess I was
Yeah.
trying to figure out what the continuum of care is. If we have people who are, not
Mhm.
insured, unemployed, or employed with non-insurance, and they maybe need more than just like a crisis call, they need some more long-term supports. Is that something that Trilogy is open to? Like, do you provide that now? I'm just trying to figure out how people find you and get into your system without some, big referral from another agency.
Sure. So typically, like we would not transport somebody because they would be unknown to us. I think an ideal world, if I think about a mobile crisis response, like you have like a vehicle, like a mobile vehicle that you and somebody else drives, and you're responding in person and have the capacity to say, "Oh, you're being discharged. Why don't you just like I can take you. Where are you going? And let's go ahead and I'll get you hooked up. Here's a couple bus cards. You need some food. I know you mentioned you need some case management. How can we make that happen?" I think that would be sort of the ideal response of a mobile crisis unit. Since we are just like individuals carrying like a phone, if we're responding as much as possible, we will like link them to services there and then say, hey, here's your next appointment. How can we get you there? Do you need bus cards? Do you have a phone? Oh, you don't. Let's see what we can do to get that sorted for you. So typically what I would do is ask like the social worker to see if we can get them transported to Trilogy if I'm not able to drive them. We do get a lot of calls for clients that are familiar to us. And, prior to COVID, like I have definitely picked some people up and driven them. Just saying like, hey, why don't you come over to Trilogy and we'll see what we can do? Or can I take you somewhere and, like, let's see how we can finish off the day with just having like a good game plan of what you need. And so typically the person responding does try to like bridge that gap and close the loop and get them connected if they're interested in receiving our services, or sometimes it may be a referral to another provider if that's of interest. Did that kind of answer your question a little?
Yeah, no, that was good. The mobile, I mean, we're trying to design the mobile response, but we also don't want to be, neglectful and recognizing that people who might need the mobile response also need that long-term case management or therapy or, wraparound support. So we don't want to
Yeah.
have this great response on the street and then nothing for you afterwards.
Yeah. Yeah, no, absolutely. I think like as I've thought about like crisis services and like mobile response, it's meant to like, manage the immediate crisis and then like link, and then how do you close the loop with that linkage? And I think it would be really helpful we have like a monthly call with Area North to like identify like who they've responded to based on like calls from the community or who officers have responded to. And then they pick up the referral, like this officer responded to this crisis that resulted in this outcome. And it bounced back to the CIT officer. So they do an outreach wellness check. that I even think that would be very meaningful. Like, hey, I received this, referral from the police department. It sounds like you had a recent hospitalization. I'm just coming out to see if like you need some supports or some services. And being able to like go out in twos and do that intensive outreach. Of course, like it's dependent on access to funding to be able to like utilize that type of approach. But I think that would probably be like the most effective.
And then my last question is, what is the, for the folks who are on this on-call rotation, what is the educational background? Are they all social workers or?
Yeah, they're master's levels clinicians. So they all have their masters. Some are counselors, some are social workers, some have their clinical independent license. So either a licensed clinical social worker or a licensed clinical professional counselor. So for us, and that's just like a Trilogy requirement to be on call and respond to those crises, you have to at least have a master's like level background. Certainly other places have done more like experience.
What time is your Trilogy kind of the drop-in you mentioned? What time is that open?
It's modified so much because of COVID. And so right now it's open to folks that are only like struggling with homelessness. Like before it was just kind of anybody and everybody. And it's 8:30 to 11 Monday through Thursday. Before COVID, it was like Monday, it was 7 days a week. Mostly like 8 to 5 Monday through Friday, and then modified hours on the weekends. So hopefully we can get back to that. It's a pretty tight space, so it was also changed for precautions.
Anyone else in the group have questions?
Oh, so is there some kind of special training that people get in order to be part of this crisis hotline response? More than just a.
Yeah, sure. Yeah, absolutely. We have not all have gone through like mental health first aid training. That has been one piece. We've done like de-escalation trainings. We, don't like do any type of restraints or anything. And so that's not like a focus of our training, but I'm drawing a blank on the name of this particular training. But we do have all of our clinicians go through like de-escalation and crisis specific training and then mental health first aid to be able to provide and respond to the calls.
Anyone else?
That's been really helpful information, I think. Gives us a good feel for pretty close to what we're talking about. Yeah.
Well, Megan, you mentioned that you were talking at 1414, I think you said. Is that the address to the drop-in center?
Yeah, sorry.
That's okay.
That's my own nuance. It's 1400 West Greenleaf.
Okay. All right. I figured it was an address. Okay.
Yeah, sorry.
All right. Well, thank you so much. And if you, I guess if you can maybe email me, I'll email you. I would love to get the crisis number. Not that we want to send everyone your way, but I think it's good for us here.
Yeah.
To have on our mental health resources, which maybe Patty and Maureen already have, but probably good for us just as citizens to know that there's another resource out there.
Yeah, absolutely.
And Megan, do you all still have, at one point you all had a bricks and mortar space in Evanston. I don't know if you all still have that space.
Mm-mm.
Okay.
I think that's our new space, right? At 565 Howard. Yeah.
Yeah.
Oh. Yeah. We just moved in there 2 weeks ago or 3 weeks ago. So that's where we are right now.
Good. Yeah, so I just wanted to add my thanks, Megan, for you joining us. We, as we were talking about different types of approaches to this plan, to actualizing and operationalizing this plan,
Sure.
it became clear, at least to Patty and I, were kind of united in thinking that, if an organization were to be considered for this, but didn't already have an infrastructure that supported outreach, it would be very difficult to just create it. So that kind of is what led to us wanting to hear from an organization that already has that infrastructure, to kind of hear how it rolls when it's delivered through like a nonprofit community mental health center, as opposed to different kinds, because the city has a number of different kinds of outreach programs. And I think we're trying to see kind of what is the best of all the kind of approaches to pull together. So I just wanted to thank you for joining us.
Absolutely, of course. Thank you so much for having me, and appreciate it so much.
Yes, thank you. Thank you for all the work you're doing in the community, and happy holidays.
Yeah, you too. And I will email that information to you. Thanks, everybody.
Okay, great. Thank you.
Bye.
All right, so I am now going to bring over, I think, or Nicola, maybe you have to do this, to bring over Rhea. And was it Christine?
Yes.
Okay. All right, perfect. Look at that technology. You guys should be able, Christine and Rhea, to turn your cameras now. Thank you. Thanks for your patience and hanging in there with us. Patty or Maureen, I'll let you introduce what's happening now.
Okay. Ted, do you want me to start, or do you want to start? Okay, so I wanted to welcome Rhea Kateria from Peer Services and Christine Somerville from NAMI North Shore. Christine is the chair of the Evanston Mental Health Task Force. And I'll let her talk about that in just one second, and would ask her to kind of introduce the project as a whole. We, as Patty and I were talking with Rhea and Christine and some colleagues in the task force, we realized that we have been, since May, we have been building kind of a way to think about crisis services in Evanston, and we're on this committee and we had never mentioned it. So rather than have us present, we thought it'd be more appropriate to invite our colleagues to present to the group, but that's why we asked them to join us, and I'm thrilled that we still have time, so this is great. So Patty, anything you want to say, and then we can let them go ahead. Nothing?
No, sorry, I couldn't find the unmute button. So, all right, thanks. Sorry.
Great. So Christine and Rhea, welcome. Would you like us to quickly go around and say who we are, or did you hear that at the beginning? You heard already? Okay.
Yes.
Great. Then Alderwomen, can we go ahead?
Oh, yeah, go for it.
Okay, great. Christine, the floor is yours.
Thank you so much. Thank you for allowing us to talk about this project. We're really passionate about it. So I'll just open it up by saying that this mental health task force, we wanted to create a tool that gave us sort of a sense of the pulse of mental health among Evanston residents, sort of akin to what we are seeing reported daily by the Department of Public Health, Dr. Azika, on the coronavirus. So, they report daily infection rates and hospitalizations and ICUs and ventilated patients. We wanted to come up with our own metrics related to mental health that we could look at in tandem with the changing physical health that gets reported daily around coronavirus. So we set out to identify the systems in Evanston that would have data that could be triangulated and analyzed and tracked over time. And our task force began its work around the pandemic onset, so around March, but it was in conception prior to COVID. And we will continue to work around this mental health issue beyond the pandemic as resources allow. So I wanted to set that as a context. We're sort of in the midst of doing our work related to the pandemic, but we see this being a long-term kind of mental health project for the residents of Evanston. So there's two parts to the data in the dashboard that Ria is going to talk about. And one is crisis data from various systems, which may or may not reflect the human experience of mental distress. They are data points that we have gathered. We've gathered, our partners have helped us gather and are in this dashboard. And then the other part is our community mental health survey, which is nationally referenced. And it is a self-reported emotional distress that Evanston residents can volunteer to share with us. So you're going to see those different parts on the dashboard as Ria presents them. So there's the crisis data as identified by these different systems. And then there's the self-reported emotional distress data. So that's sort of how we've envisioned looking at this so we can move forward with helping the community. So I'm going to turn it over to Ria now to walk through the dashboard, and then we can answer your questions. You're on mute, Ria.
Oh, sorry. All right. Does this work? Can everybody see the dashboard? Awesome. Okay, so welcome to our Mental Health is Essential dashboard tour. So what I have here is sort of a draft of the data dashboard, if you may, that highlights the different local infrastructures that COVID-19 has impacted upon, as Christine mentioned. So each element illustrates sort of the city's response to the pandemic, as well as the people in crisis. A few sort of caveats to note before we move on is that this is a very dynamic dashboard that has room to grow, so all feedback is welcome. This is also just a draft. How the dashboard could look, its actual location and functionality will be determined by several factors. And lastly, the data is currently confidential and limited to this work group. And let me know if I'm talking too fast. I'm trying my best to cover all of this in a very short time. All right, so let's begin. We know that there has been a significant pressure on local infrastructures that has impacted mental and physical health of our community. So encompassing the dashboard data around the COVID-19 case data not only helps put these changes into context, but also sort of reminds us of the importance and the continuing need for information to be available and to be recorded. So we thought it was important that our data was kind of encompassed around this first visual chart of the Evanston COVID-19 daily cases. So moving to sort of the top bar here and the About section, it introduces viewers to what the Metrics Initiative is about, our goal, which is essentially to collect relevant data to paint a picture of our community's health. As you can see, there's also room for a resources section and a help section, which is currently unlinked, but it has room to include our resource guides or education materials. You can have links and helpline numbers for assistance. Moving on to our main chunk of different levels of infrastructure. To begin with, the EMS or fire department, we note that the tracking number of people who call regarding mental or emotional distress or a drug and alcohol issue could indicate the level of crisis. So for example, in the chart here, the points or dots illustrate the total number of calls received, whereas the bars represent the percentage of those calls that were logged under some category of mental distress as the chief complaint. So for the first one in 2019, quarter one, there were 156 calls, 92% of which were logged under some category of mental distress. So this chart can be really helpful for that reason. There are other, as we move on to more sort of specific level data, not just where the calls were, specific level data where the chief complaint was alcohol intoxication and drug overdose, you can see the changes. So as you can see, we also have included sort of a space right here on the right. I'm not sure if you can see it, I can't, because you guys are right here on the right, there's a bar that sort of talks about the data for people who are not well versed with data or can't read charts, have sort of a space to explain the data in very user-friendly ways. So if you look at the drug overdose data, which are just the green and the blue points, you can see that there was one call in 2019, and there were 33 calls in 2020. That's a 32,000% increase in calls. And, this sort of kind of parsing of data can be very helpful in seeing these sort of surprising numbers. Moving on to sort of anxiety calls, again, you can see how the calls changed over time from 2019 to 2020. And I'm sure you will have access to this dashboard later, so don't worry about actually looking at every specific point. In the demographics section, we have sort of the age distribution of callers in 2019 only. We are waiting for calls for 2020, data for the calls of 2020, so that'll be a more interesting data point to notice after we have that. So moving on to schools or District 65 data, we know that families reach out to school counselors for help. So the current data we have is around suicide risk assessments and DCFS calls. As you can see here in suicide risk and DCFS, both categories show a distinct fall after March 2020. So this can be attributable to, of course, school closures. But I think also the more important kind of outlook here is, it kind of points out the unmet needs of students in distress after that point, because it's such a sudden drop in data. And that definitely could indicate that students are in crisis and their needs are not being met. So with regards to the emergency departments, we currently have data on the number of mental health crisis assessments conducted at St. Francis Hospital and North Shore from April of 2019 to March of 2020. So as you can see, the trend remains fairly stable before sort of dipping in early 2020. So as we do receive more data for this year, we will be able to make educated guesses and possible inferences about how the trend has changed as the pandemic progressed. Next, we have the police department. An interesting nugget of data we received here was regarding the number of drug overdose incident-related calls made to Evanston PD, which you can see have almost doubled from 11 in 2019 to 20 phone calls in just the first half of 2020. So this is concerning when you think of it in terms of the pandemic and how many people are and will continue to stay at home alone and more isolated. We definitely do expect more data to come in for this, but next up we have 311 calls via Amita's distress helpline. So here, this reports callers that have identified themselves as Evanston residents while calling about a mental health concern. The chart is interesting as it shows a consistent sort of downward trend. Again, does this mean that fewer people need support, or does this mean that people who do are not reaching out for help? It's hard to infer a certainty, but the data is helpful to track over time. And finally, we reserved, like Christine said, a space to display results for the community mental health survey that was launched late November this year. We hope to monitor the community response to and post COVID-19. This data is not meant for academic research as much as it is meant for us to get a temperature of the community, how they're feeling, what's helping them cope. The displayed data is just for a slice of the respondents. These are not all the respondents we have so far. We will have more comprehensive data visualizations once we have completed data collection. So this screen indicates the overview of the respondents whose data will be displayed. As you can see, the majority of respondents identify as white, female, and are either employed or retired. So this is not representative of the Evanston population, whose numbers are displayed here on the side as a point of comparison. So the survey highlights some key indicators of mental health, first of which are self-reported levels of distress that are nationally referenced. So as you can see, the different chart shows different colors for different responses as listed. So our high frequency colors are the reddish orange and yellowish orange ones. As you can see, they are extremely low for something like I have felt worthless, but they are the highest for I have felt nervous. However, also good to note that except for I have felt worthless, more than half of all respondents have experienced all of these distressed emotions more than a few times in the last 30 days. Let me give you a quick second to just look at the chart. It can be a little tricky in the beginning to see, but it's really eye-opening. And while we cannot make, for certain inferences out of the chart, it's just good to look at just to see what the community is experiencing. Okay. So the second indicator that we have is substance use and change in substance use behavior. So we thought it would be helpful to include use of legal drugs like alcohol and marijuana, but also we left room for other substances that people might use and either might not be comfortable sharing or might not even recognize it as drug use. So our observations show that a good number of this response pool had upped their alcohol use during COVID, but overall mostly remained the same, or in the case of cannabis, were absent. The last indicator we measured, I'll give you a couple of seconds to look at this. Okay, so the last indicator that we measured were key sources of support utilized by the community. So we listed 8 sources of support and also provided an other option. So out of the 8 items provided, connecting with friends, exercising, and spending time with family were the top 3, as you can see. There were also many people who actually wrote down their own different ways that they're coping. And we hope to illustrate those responses in the future as maybe inspirations or different ideas for community members. So it's a great way to really get a lot of information around what community members are doing to either to keep themselves busy, to cope with stress, or to just, get by during this period. So we do believe that all of these indicators will provide a descriptive value as well as inform the city about the direction and need for future programming efforts. We have a space for demographics here listed that will be linked once we have more comprehensive analysis of the data. So yeah, and then back to the beginning, again, like I said, more room, very dynamic. That's all I have for you today. I'm sure it's a lot of information to take in. Very sorry if I kind of rambled on. Like I said, we're very passionate about this, passionate about the data. We really believe that this dashboard could be a growing resource, which could be nourished with increased feedback and expected data. So thank you so much for your time. I'll pass it on to Christine for final comments.
Do you want to stop? There you go. Yeah, I wanted to just let you know that we plan to keep the survey that you saw the data on open until April, and then reissue it again as a summer survey. So we're going to do it 2 times yearly. And then we'll be able to track over time how, people's distress changes. The dashboard, we're hoping to be hosted by the city on the website, and also may be available to others at request. I mean, we're just we're kind of indicating this is a work in progress, so we don't know the final destination of all this information, but it will be public. Our intent is to be able to see the changes over time in these metrics that can help inform how we can respond to the community need, and we as mental health professionals can respond in particular. So we're happy to answer any questions, and thank you.
Thank you all very much. That was quite impressive, but that you were able to gather all that information. Does anyone in the group have questions?
I do. Thank you for that presentation. I'm curious around one point that's important for me is how we lift up the mental health and well-being of survivors of community violence. And those incidents have increased during COVID. And I noticed that in the Evanston PD category, there was only one bucket, right, of reporting. And so I'm wondering if there's thought around that in terms of bringing in the realities of community violence in this moment in time.
Yeah, I think this is the kind of forum that helps us understand what your needs are. And so we will make a note of that and, see if we can mine that data, if we can gather that data and mine it so that it's useful to people like yourself.
Mm-hmm. Yeah, because I don't think, those incidents come in as, reports of violence, but there isn't often an afterthought in terms of the mental health and well-being of the survivors, right? And the needs that we have and how they're exacerbated by a pandemic such as COVID, right? So there's so many layers to that. And then the other question I had was around the survey. Is that being issued in multiple languages currently, or if not, are there plans to do so?
Yeah, I forgot to add that in. We do have the survey available in Spanish also. We have not yet combined both of those data points. So this one was just a slice of the English one. Yeah.
Great. Thank you.
And
I was
Go ahead,
wondering-
Angela.
I was wondering if you had any designation in there for people who perhaps struggle with long-term depression versus people who have situational depression. How are you monitoring responses for that?
So if you're talking in regards to the survey, and like I mentioned, I think the point of this survey was not to dig in that deep and go to that sort of academic level that would require a lot of sort of vetting in terms of even standardizing the survey. This was just sort of our very like basic way of getting, like I said, just getting the temperature of the community without also overwhelming the community to answer too many questions about themselves, which could also sort of lead to even just a small amount of trauma to write those responses, especially in the conditions that we're at. So I think that was our sort of goal with the survey, is just to provide very basic data, few questions, won't take too much time to answer sort of the situation.
And I can add in that I know the survey was offered. I don't know how many people took it last month at the food pantry, where you would probably, capture people who you won't capture through regular means of communication. And there is a pantry this Thursday if you all are still collecting data, if you want to come out as well. But my other question, then, you mentioned this going on the city website, which in theory is a great thing, but also gives me a little bit of the heebie-jeebies because the website is just so all over the place. But what are you using this information to communicate to the mental health providers or even potential funders, right? Like, because I always think about where are the gaps in mental health service. And I know we're trying to think at the city about a better way to allocate our mental health funding. And so it's not just the same, $5 here, for like, really, how can we make a more tangible impact, and maybe just filling where there are gaps. So have you guys identified some of those gaps? And then how are you using this data in your group?
So this dashboard is one of 3 projects that our task force is working on. One is an education campaign, and one is a resource guide. And the resource guide is now, it's just been published in the city e-newsletter, and that answers the question of where are the gaps. I mean, it doesn't answer the question, but it provides what we were doing is the committee looked at all the resources available and noticed that that the biggest gap was for around low income individuals and communities where there wasn't access to clinical services that they could afford. So the resource guide lists all of the resources available that are either free or on a sliding scale for low-income individuals, and also for individuals that are looking for support from our Black and Brown communities, our Latinx communities. So that resource identifies where the services can be available, free or at a low cost. So that was one of the gaps that we looked at. I don't know if Maureen or Patty want to comment any further on that, but we were concerned about that. So another subcommittee worked on that project.
I think when we think back to the sort of the data in the dashboard from different either public systems or significant institutions that serve the Evanston community, we had this sort of hypothesis that we would see a real increase in crisis calls related to mental health during the spring and summer related to COVID. And so that's why we asked for baseline data by quarter from 2019 so that we could see if there was a progression, what it looked like. And honestly, it was the opposite of what we were expecting to see. It's possible that as we are able to, because this is an all volunteer effort. So, as people are able to, different city agencies and institutions are able to provide us with their data, it's possible that we'll see different trends with like data catch up and so forth. But I think what what we've started to think about is, there's no shortage of people in significant distress. Between losses from COVID, loss of jobs, loss of housing, the racial violence the police violence that we witnessed this summer, and everything that's come together, that Evangeline talked about the deaths in the communities. What we have been through this year could make any of us, let alone all of us, very significantly distressed. And the fact that we haven't seen that manifesting in like lots more crisis calls raises the question, like, what's going on, right? And where are people getting support? And the good news would be if people are finding more natural support with each other, like that would be a great outcome of the pandemic. I don't know that that's happening, and I don't know what's going on. I know we at Peer are very concerned about the students who were already very much at risk that we were working with, who just disappeared. Like we can't get to them through the schools, and nobody knows where they are. And so, and that's a relatively smaller number of students, but still very concerning. So when I reflect on the dashboard myself, I feel like it's sort of halfway to its useful potential, but we haven't figured out what the end kind of status of it is. And that may have something to do with, how it fits into this bigger picture of crisis response. And maybe because that's still forming, we don't know the answer yet. So I'm not sure, but I have high hopes for this as useful information still.
Any more questions? I will throw out another thing, and Maureen and I worked on this a little bit when I was at the county, and there was an article maybe today or yesterday about COVID-related deaths in Cook County. Did you see that, Maureen? And I think all but one that were listed in the paper also had an overdose component to it, or not overdose, but a drug component. So I appreciate that you guys have that on there. And I know our police and EMTs have been trained to use the appropriate medications, but that is something that, I will have to track through the winter, right? And James will be very helpful with us for that, because we're going to have more folks, I assume, who are outside this winter. And then when the moratorium on evictions is over, right, next kind of early spring, late winter, I'm anticipating that's when we're going to see the fallout from that. And, that'll be a whole slew of other issues that we'll be facing as a community. All right, any more questions for the mental health task force? Well, thank you all so much for presenting to us, but also for all the work that you've done in there. That was really helpful. And I know I did see the little paper with the boxes on it, I guess was the resource guide that you guys put out. I noticed that Northwest CASA, which responds to sexual assault, was the only one that was a free provider, and that was quite disturbing to me. I think they were the only ones that were they not the only ones? Okay, I might be wrong then. Okay, I browsed that a few days ago, so thank you for correcting me. I thought that was the one that stuck out as like a free support.
Yeah.
But Rhea, what's the other one that's free?
I think there's another one that's free. I think all of them have some sort of a free component or take insurance. I'd have to look.
Okay, I'll revisit it because I know that one stuck out, and I know there was some sliding scale, but I thought, sliding scale could be great unless you have nothing to slide, and then we're still looking at, potentially.
And I would offer that even free and sliding scale have a barrier with wait time, right? So if you're in immediate crisis, sometimes it's a 3-month wait to get help. So that's another challenge.
So yeah, I think Impact has Impact here. Patty can speak to this. Has a free component, and the Family Institute of Northwestern, their clinic is free until September 21.
Yeah, and we actually have been working with different community providers that don't have clinicians that we have space in our clinical program, and we generally take Medicaid folks. We don't have a wait right now, so we've been trying to get the word out around that as well. And if folks don't have Medicaid and come to us with no income, we have a benefit specialist that helps people navigate the system.
No, thank you. All right, so Christina, Rhea, feel free to have the rest of your afternoon back. Thank you so much.
Thank you.
One more thing, committee, while we have a couple of seconds, I want to do is DC Barnes is on the call. She's been off camera, but I wanted her just to give us a couple minutes update on when Trilogy used to work more in Evanston. She had some experience with them. So DC Barnes, are you?
Hi, everyone. Sorry, I'm multitasking again.
That's
but
okay.
Thank you. So I just wanted to mention that many years ago, when I was a new commander running the patrol midnight shift, my experience with Trilogy was fabulous. They came out to the station and they assisted with at least 3 mental health cases that I recall. They walked the client through the paperwork, accompanied them to the hospital, and I believe even kept in touch with them afterwards. But shortly after that, it seemed like the funding dried up. So I haven't had any experience with them lately. I'm not advocating for one particular agency or over another, but I did just want to mention that I had a good experience with Trilogy. And also, I would be remiss if I did not mention that we have had some cases here as of late where the violence has really escalated with some of our mental health cases. So just something food for thought. Thanks, Alderman.
But okay, yeah, thank you. But back for the Trilogy part, was that something that, do you recall if they were like contract with the city, or did someone in the station just know that Trilogy provided the support, so they called them to come out? How did the connection get made?
They actually came out to our roll calls, and so they were separate from the city, but they came out and just gave us a presentation on what their agency was doing and worked with us if we gave them a call when we encountered clients.
Oh, that's great. Okay. And then to the second part about the mental health escalation, can you give us a little more context for that? 'Cause I know she definitely mentioned that responding by herself, which I don't think any of us think is a good idea, but what are you seeing now there with mental health clients or residents?
So, well, what we're seeing is, it's not predictable, and the propensity for violence is great. And so it's hard to determine case by case who may have an episode that would result in violence or who may not. Sometimes people are familiar with some of the clients and they may be able to say, I know that person won't react, in a dangerous or violent way, but a particular case I'm thinking of now, it was a total random stranger. And so the police did get there and encountered the offender, who was very violent. So it's a good thing that they met with that offender first, say, versus if, someone else had went out by themselves.
Okay. And without looking at numbers in front of you, do you feel like the calls that involve mental health, be it, violence or not, are escalating?
I would say recently, yes. I'm not saying that it's a trend in terms of every case, but I can think of 2 cases as of late within the last couple of weeks or so. And one involved a family member of an individual. So it's just food for thought.
Okay. Patty, you have a question? Go ahead, Patty.
And I was just going to chime in real quick that based on the data that we have just in-house from our participants, the time from right before Thanksgiving through the end of the year, it really, our participants are a lot more amped up, and we're fielding a lot more after hours calls and things like that. So that certainly falls in line, I think, with what's happening.
All righty. All right, folks. Well, thank you for staying later today. So we're not going to meet next week. I am going to start. We do have our Google Drive, if anybody's looking at that, for just kind of articles here and there, but I'm going to start kind of putting together what we've talked about in terms of just in our discussion times. I know we still have a little ways to go, but at least we can start kind of formulating some kind of working document. So I'll send you an email when that's done. There's no pressure at all to work on this over your holiday respite. But I do want to just get some stuff written on paper so that when we have thresholds and maybe the folks from Cahoots come in, we can start formulating something a little more. Autumn Ravel doesn't know, but she and I are going to start really getting on this other line of money.
All right.
It might be possible. And then, you know, when we come back in January, I'm going to start getting some things to stick to a document to present to council. So I am going to assume people are going to take a full advantage of the holiday season. And so they're not going to be working that first Tuesday of the new year, which I don't even know what that date is, but I'm going to assume everybody's going to rest their brains and their souls after this year as we all meditate on a very safe and positive 2021. So the first Tuesday is the 5th. I'm happy to meet then. I am going to be here and not resting, or we can meet on the 12th. So I'll send that out. You guys can just email me, let me know what works. We'll go with the majority there. And then we'll plan on going to Human Services. I assume they will be meeting on the 1st of February will be my guess. So that'll give us a few meetings before we go to them. And we're just going to them with like, here's what here's what we're thinking. I don't know if we'll have a full proposal or just some ideas, get a little guidance, get a better understanding of the money, and then I would assume kind of formulate our final plans based on that feedback we get.
Sounds good.
Okay. All right, you all have a great holiday.
Yeah. Happy holidays, everybody. Good to see you. Thank you.
The food pantry,
Thank you, sister. Thank you, everyone. Have a great day.
the food pantry is open on Thursday. That's my last plug because that's the last one for the year. So no sign up, just an Evanston ID.
Right.
James,
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.